Medurstand, Understanding Medicine.
I am Professor Aziz Rehman, and today we are going to discuss the diabetic complications. And I will be able to give you an overview because detailed discussion is beyond the scope of my lecture. And because there's so many of them and detailed discussion will take a lot of time. So in today's lecture, I will give you just an overview. And diabetes, especially type 2 diabetes, is mostly asymptomatic and mostly an incidental finding. And whenever you offer treatment to the patient, number one, we change patient's lifestyle and then we give them medication. A patient needs to be convinced why he has to go through all this because he is not having any symptoms. In fact, the medication is going to, or at least may give him some side effects, and it's certainly going to cost him some money. So we need to explain to him that it is the diabetes, it is the complications which make this disease a bad disease. There are several types of complications. Some can be present at the time of diagnosis, but typically, I think most patients would not have any symptoms or any symptoms related to complication in the first 5 to 10 years. So, patient would not feel convinced, patient would not feel compelled to take any treatment. We need to explain to the patient the natural history of this disease and explain to him that these complications can occur and will occur if diabetes is not controlled, and now is the time to do something. So I hope this overview will help you to understand these complications, their mechanism, their early recognition, and what we can do about them. Uh, Diabetic complications can be classified into three groups. A small balloon indicates metabolic complications. Now, these are direct effect of insulin, and luckily, these are becoming less and less common. And then we have a group of complications which are called microvascular complication because pathogenesis is common. There is involvement of small vessels and that cause this group of complication. So I think then we will deal with them separately. And then bigger chunk, most complications, the biggest cause of death and morbidity in type 2 diabetes comes through the macrovascular complication. Those complications which are actually related to premature and accelerated atherosclerosis. And I will just touch upon this in this lecture because this deserves a separate lecture in itself. Our next lecture will cover microvascular complication. Now, what causes diabetic complication? Why it is important? Because we cannot treat anything unless we know the cause. Now, scientists, they have tried to find out what exactly is the cause of these complications. Is this just chronic hyperglycemia, or are there any genetic factors, or there are some associated factors, or the factors are still not known? So I think we have only partial information. I'll just share with you some of the information I've got. And microvascular complications, which I'm going to show you the three groups, they are the effect of chronic hyperglycemia. Now, what is the importance? The importance is that justifies that we have to focus on the management of chronic hyperglycemia. So hyperglycemia has to be managed on long-term basis if we really want to prevent these microvascular complications. So hyperglycemia is responsible, and whenever there is chronic hyperglycemia, depending upon the degree and the duration of hyperglycemia, there will be glycation of tissue proteins. Now we know very well glycation of hemoglobin, and I'm sure you also know, and that is used for the diagnosis and for the monitoring of diabetes. But actually, practically all tissue proteins can get glycated, and we know, for example, lipoproteins can get glycated. So they can actually contribute in the pathogenesis of complication. And this may be reversible. Chronic hyperglycemia is of course reversible, but glycation of tissue protein is also to a certain extent reversible. But as things go on, advanced glycated end products are made, and this is a kind of irreversible. So as the time passes, something which is reversible is becoming more and more irreversible, and then complication occurs. And very unfortunately, once these complication occurs, microvascular complication, once these occur, we cannot revert them, at least to a significant extent. But we can certainly control them if we can maintain normoglycemia or near normoglycemia. Now, macrovascular complication we are going to discuss in a separate lecture, but in addition to these advanced glycated end products, there are several other factors, and there are many associated conditions which contribute to the pathogenesis of microvascular complication. Now, this is again same cartoon indicating three different groups. Now, let's take up metabolic complication in some detail. There are three disorders. Diabetic ketoacidosis. This can be the presenting symptom in type 1 diabetes. But please do note that even type 2 diabetic patients, when they have severe insulin deficiency, or when they go through a severe stress, or when they are on SGLT2 inhibitors and also have some kind of infection, they can develop diabetic ketoacidosis. Now, hyperglycemic hyperosmolar state is another complication, and this is typically seen in type 2 diabetic patients, especially those who have severe insulin deficiency and they develop frank hyperglycemia and then maybe coma. And then in rare cases, those with diabetes and underlying kidney disease, especially if these patients are treated with metformin, they can develop lactic acidosis. Now, there is going to be a separate lecture on metabolic complication. For now, I think this much is enough, but I'm going to have a complete lecture on diabetic ketoacidosis and other metabolic complications. These metabolic complications are direct effect of insulin deficiency. So that is why in type 1 diabetes, straight away we start insulin. If somebody does not take insulin, he is likely to actually present with DKA because insulin is absolutely essential. So, and mostly it is in type 1, it can occur in type 2 also. It is preventable by early recognition. By proper usage of insulin, it is preventable and it is treatable. We understand exactly everything about diabetic ketoacidosis. It has got complex metabolic derangements. We understand them well, and all of them need to be addressed individually in addition to replacing insulin, and they are treatable. So I think, and as I said, we will have a separate lecture on DKA. Then we take microvascular complication. There are three conditions. Diabetic retinopathy, it's self-explanatory, involvement of retina, although in eyes you could have other complications related to lens, related to refraction, and there could be glaucoma. But here I'm just going to discuss retinopathy in some detail because that is actually the direct complication of chronic hyperglycemia. Then we have nephropathy, a progressive kidney disease, and neuropathy. These three microvascular complications, they have something common. They are caused by the microvascular disease. Chronic hyperglycemia is responsible, and but once these complications develop, they are mostly irreversible. We can prevent them by intensive control, and UKPDS has shown us, and many other studies have also shown, that with intensive glucose control, we can substantially reduce the risk of these complications. So that is very heartening. That is actually the reward patient gets. If you can keep glycemia well under control, we can prevent or at least delay these complications. These complications may be actually life-threatening or organ-threatening, or maybe very, very distressing. So I think it is very important to prevent them by keeping glucose well under control. Now, just few more words about diabetic retinopathy. You can see this picture. This is taken from the internet, and it is recommended that in type 2 diabetes patients, we should have a dilated fundus examination by an ophthalmologist, and then every 5 years. Now, why at the time of diagnosis? Because we know that type 2 diabetes may remain undiagnosed for some time up to 10 years. So it is possible that this patient might have been undiagnosed for some time, and he might have actually already developed some kind of diabetic retinopathy. Although I believe in majority you'll find normal fundus, but you must at least ask your patient to go to an ophthalmologist and have a dilated fundus examination. That means we dilate the pupil first so that a complete retina can be examined. And there are various abnormalities. It is actually two types: background retinopathy. That means there may be various types of exudates. These white spots, these are exudates, or there could be various types of hemorrhages. Both indicate vasculopathy. So you are actually looking at the vessel. Fundal examination actually provides the opportunity to see the vessels. The microvascular disease can be actually seen with your own eyes. So never miss this opportunity. I think the physician should be able to do it himself. I always do it myself. But of course, a dilated fundus examination by an ophthalmologist would have more value. So I think these can be easily recognized. Then we have proliferative retinopathy. Usually there is background retinopathy, and if that is ignored for several years and glycemia persists, hyperglycemia persists, then this leads to proliferative retinopathy. By proliferative retinopathy, we mean there is neovascularization. Because of chronic ischemia, first there is microvascular disease, then there is ischemia. That ischemia promotes new vessel formation, and new vessels are very, very frail and liable to rupture, and they cause major hemorrhages. Vitreous hemorrhage could lead to glaucoma. So I think proliferative retinopathy is something really serious. And then there is macular edema. These are advanced retinopathies. I think these patients should of course be under care of an ophthalmologist. Now, diabetic nephropathy, this cartoon shows, this is again from the internet, and you can see a structure of glomerulus. Now, there is a lot of hyalinization. The normal structure of glomerulus is replaced by this hyaline tissue. That means that glomerular filtration will be affected primarily, and it is like primarily a glomerulopathy, and that will result in albuminuria and reduce glomerular filtration rate and progressive renal failure. I think every patient at the time of diagnosis must have a simple, complete urine examination, and you must also estimate creatinine. Now, urine complete examination, if it shows proteinuria in the absence of cells, that indicates that patient has already developed Microalbuminuria. So if urine is clear, I think then in the next visit you may ask the patient to go for the next test, which I'm going to show you just now. Creatinine should be done But you must also try to calculate eGFR, estimated GFR. Many apps are available because serum creatinine, certain value in two different individuals could actually mean different things. For example, creatinine of 1.1 milligram per deciliter may be normal or acceptable for a person who weighs 100 kg, but same may indicate fairly advanced nephropathy if that person is only 50 kg. So I think these formulae, they allow you to calculate the eGFR, which better reflects the kidney status. So, and this is free, available online, so you can, and they're downloadable apps. So I think you must develop the habit of calculating eGFR for every patient. Now, microalbuminuria, as the name says, it is the presence of small amount of albumin in the urine, and so small that it cannot be detected with a simple urine examination dipstick. It has got a special technique to pick up, and a very small amount like 30 to 300 milligram per 24 hours would constitute microalbuminuria. Now, it of course means that if it is more than 300, that would make it macroalbuminuria. And that also means the less than 30 would be normal. Now, please note down, this test would require 24-hour urinary collection. So that of course is possible, but cumbersome. Now, we have, I think, a better test which is more convenient. We can do albumin to creatinine ratio in the morning sample of urine. So it would reflect the same presence of microalbuminuria. This would be a better and more convenient. You just ask the patient to go to the laboratory in the morning and have this test. So laboratory people will collect the urine and they will estimate both albumin in milligrams and creatinine in grams, and they will express that value, and then you can see if this patient has got abnormal amount of microalbuminuria or not. Now, what is the importance? You would think that microalbuminuria indicates the presence of early nephropathy. If you think that way, you are right. So that is true. It actually indicates the presence of renal disease already is there. You mean that it means that the kidney disease is already there. Although patient is not having any symptoms, but it is already there. It is going to progress to next stages, and ultimately it could cause renal failure. But perhaps more important than that is that this microalbuminuria, it actually reflects the presence of overall vasculopathy. So if it is an overall vasculopathy, it could actually represent the increased incidence of atherosclerotic cardiovascular disease. And that is actually true. Those who have microalbuminuria, they are at much greater risk of developing atherosclerotic cardiovascular disease 10 years down the line. So we got warning 10 years before some major complication is going to develop. I think we should make use of this information, and every patient should have this microalbuminuria. If this person has microalbuminuria, then not only you intensify his glycemic control, you also revisit his associated conditions which contribute to atherosclerotic cardiovascular disease, so that we can address them and we can prevent these complications in future. Then typically we use angiotensin converting enzyme inhibitors and angiotensin receptor blockers. Of course, if they are hypertensive, many patients with kidney disease, they also have hypertension, then you use these agents. Most societies, including American societies and European societies, they recommend that hypertension in diabetes should be preferably treated with ACE inhibitors, particularly if they have albuminuria. So I think that makes a very strong case for these drugs. But the point I would like to mention here is that even if these people are normotensive, they do not have hypertension according to the usual standard of 140/90. Even if they are normotensive, I think giving them ACE inhibitors or ARBs in relatively small dose, which they can tolerate, will definitely be very useful and makes a lot of sense. So we use these agents in these patients. Then of course we try to provide best glycemic control, and in my lecture on medication I made a point that insulin is the most potent glucose lowering therapy. Now you can see if you can manage this patient's hyperglycemia with manipulation of oral, and some orals are actually contraindicated when a patient develops frank nephropathy, but in milder disease, many orals are allowed. So either you make appropriate adjustment in the oral antidiabetics or you switch over to insulin, because we want to achieve best possible glycemic control. So this was about nephropathy. I think there's one more bullet. Yes, there are various stages of CKD. The stage 1 is actually hyperfiltration, and many times I see patient bringing a report and worried about his creatinine, which is actually lower than normal. Although it is lower than normal, perhaps indicates the first stage of nephropathy, that is hyperfiltration. But in a very light mode, I just lighter note, I just tell my patient that your kidneys are better than normal. But at the same time, I go through the prescription and see if I can improve their glycemic control. And of course, there are stage 1 based on EGFR. You could classify a nephropathy any stage. 5 is of course the one who is end stage renal disease and needs some kind of renal replacement therapy, either dialysis or kidney transplant. We of course do not want our patient to go to that stage, but unfortunately that does happen sometime. But if you control glycemia and other factors well, then fewer and fewer patients should go to that stage. And further discussion of course is beyond the scope of this lecture. Diabetic neuropathy, again I will be able to give you just an introductory part, because there are many types of diabetic neuropathies, and the commonest is peripheral sensory motor neuropathy, the peripheral neuropathy, and most important the sensory component. And these patients are very symptomatic, very annoying symptoms, and they may also have mononeuritis or mononeuritis multiplex. Now this is just one nerve. It may be facial nerve, it may be third nerve, it may be sixth kidney nerve, or fourth kidney nerve. Any nerve in the body can actually be involved in mononeuritis. The mechanism of mononeuritis is different than peripheral sensory motor neuropathy. This is an axonopathy, which means it's a permanent, and this one is luckily reversible. There is involvement of polyol mechanism, and there is actually deposition of sorbitol in the nerve that causes edema, and that causes temporary nerve function. And if you control the glycemia, I think I would use insulin in this situation, because I want to make sure that sugar is controlled, glucose is controlled, and then within 6 to 12 weeks this is actually reversible. If more than one nerves are involved, but the mechanism is same, we call it mononeuritis multiplex. Amyotrophy, a type of neuropathy where muscles are wasted. Radiculopathy, where there's a sciatica-like syndrome, there's a shooting pain starting from the back going to the leg, and then various type of entrapment syndrome like carpal tunnel syndrome, wrist drop, other things. So all these types of complications are possible, and I think the commonest is this one. And every patient at the time of diagnosis should be examined thoroughly. The neurological system should be examined. And we have recently learned that some patients, they present with neuropathic symptom. Type 2 diabetes, they have neuropathic symptoms, but when you control their glucose, their neuropathic symptoms, they go away. But when they develop the same symptoms later on, then they are usually irreversible. Very interesting fact that somebody who is on oral hypoglycemic agents not responding very well, and we intensify his treatment by adding insulin, and he may develop symptoms of neuropathy at that time, or if he had symptoms he could actually have worsening of the symptoms when that glycemic control is tightened. We do not understand, at least I don't understand the mechanism fully, but we do know that this can happen, and we have to explain to the patient that this is a temporary state. You will be benefited ultimately, but temporarily you will have these symptoms. Now the symptoms are nocturnal leg pain, and this could disturb their sleep, and they may be then not feeling well during the day. There could be needles and pins and pricks feeling, and ultimately there may be loss of sensation. And these can be managed symptomatically, but loss of sensations is irreversible and there's nothing that we can do. So I hope that we can manage our patient at an earlier stage and prevent this thing happening. Symptomatic control with the pregabalin. Now, since we cannot reverse these complications, these annoying symptoms can be managed with various drugs. These are actually anti-epileptic drugs or antidepressant drugs, antipsychotic drugs. There's a whole long list. I've just picked a few which are commonly used. Pregabalin, used from something like 25 milligram to 300 milligram plus once at night or maybe twice. Or gabapentin. Gabapentin is again useful drug. This is also an anti-epileptic drug. The dosage is usually higher than this because this is 3 times less potent than pregabalin. But there are many other drugs. I think traditional tricyclic antidepressant drugs may also be used. Some local applications may also be used. But let me tell you, this is very, very annoying symptom, and patient would want to do whatever it takes to have their symptoms relieved. Of course, we like to tighten their glycemic control. I'm not sure if that will stop further progression of neuropathy, but at least we know that patient is heading toward other complications, so we definitely need to give him better glycemic control. These patients are also at an increased risk of developing diabetic foot and what is called hypoglycemia unawareness. They are at more risk of developing hypoglycemias, and they might not develop those symptoms of warning symptom of hypoglycemia. So that is another problem with neuropathy. Now we have discussed very briefly metabolic, because that we are going to cover in next lecture. We have discussed microvascular complication in some detail, and macrovascular complication just a mention here, but we are going to have a separate lecture on that. These are due to premature atherosclerosis, ischemic heart disease, various types, cerebrovascular accidents, various types, peripheral artery disease, again various arteries can be involved. And this is the effect of chronic hyperglycemia and many associated conditions, and the tight glycemic control has only modest action. And when we go through this UKPDS, the patients who were on tight control, they only have modest benefit. I think this I will discuss in greater detail in the next lecture. So that brings us to the end of this lecture. This was about an overview of diabetic complication. I hope I was able to give you some information, some useful information, and I really look forward to see you in my next lecture, and that will be focused on atherosclerotic cardiovascular disease in type 2 diabetes. And I've already mentioned that 75 to 80% morbidity and mortality related to type 2 diabetes is through atherosclerotic cardiovascular disease. So that makes it very important. So I'm really looking forward to see you there. I think don't forget to view that video. And by that time, I think I'd like to thank you and stay well. Thank you very much. This was Professor Aziz Rehman from Medurstand, Understanding Medicine.